programs on making the pediatric epilepsy is a broad topic. It's not same as being it's different altogether. Epilepsy syndrome is
We're having a problem here back here.
So I don't have anything to disclose. Objective today is to talk about what's a seizure, what's an epilepsy, what's an infected epilepsy, what are the pharmacological management of this condition. CBD, cannabinol, and Epidiolex, that's been commonly asked questions by faculties who want to try those medications, and it's available on Congress as well, and that's a normal test. And then certain methods of epilepsy, and lastly, finally, consider which is some unexpected epilepsy. So, epileptic seizures. So, when a seizure happens, it can be because of either brain condition or a seizure can be non-regular condition. The example is if you're brushing your teeth and let's say you may walk into a seizure, and that does not mean that you have epilepsy disorders. Epilepsy has to come disorder. So whether you have an abnormal, excessive, or synchronized activity in the brain, which is the reason we do EEG to help us understand is it from the brain versus it is not from the brain. That means it needs normal activation of the brain. Now, in this 3-year calendar, which is important for is more of concept how the seizures start and how it interpreted and what are the clinical symptoms with that patient illness. And the analysis to see and all that additional and finding out so here I have a seizure. Starting with the seizure of the child, the baby. So we begin to see the students up. So it's a object that is lightning. There's a distance, which gets off with this time. So this is a seizure in a baby. So you can have seizure starting from G1 to and so if you have a seizure, what's the likelihood of having a second seizure or a third seizure? And there's a good study done and here shown in its publication that if you have a one seizure which happens in 204 patients, all of that, what's the likelihood of the second seizure happening within a year? And that's 21 of 204 patients. And by the end of the 16 months, 5 years, 33 patients have seizures. If we just happen to have one seizure in that time, then this is the likelihood of having seizures in 33 patients. And number of patients who are seizure-free at 12 months is 153 because 60 of them have had a single seizure. And then if you have a second seizure, what's the likelihood of having a seizure in plus 12 months to 16 months? That is 73% of that will have seizures, so 24 will remain seizure-free. If you have a third seizure, then within a year, the likelihood of 12 people becoming seizure-free is 5 years. So what it means, seizure begets seizures. So one seizure, second and third seizure goes up. And your chances of having seizure freedom goes down. So that's the reason our goal is not to have a second seizure. And how do we do that? So that's why we prescribe seizure medication to prevent to see how likely the seizure medication also works. So we don't want any procedures if the patient has a seizure a second, they're not likely to have a third. So this graph is another way, 0 period to 100 months old. And this is the same graph which shows the first year you have 104, and then within the year you have second seizure, 60 patients have it, and the likelihood by 36 months in patients who are 3 seizure is 103 compared to 103 at 36 months. So it is very important that we try to prevent the seizures. Now, if you have, we always like to get an MRI if you have a seizure to see whether if you have underlying structural problem, you have trauma, or you have a tumor, or you have an hemorrhage. So that's the reason. If you have normal MRI, you don't have any abnormality, then your likelihood of having a seizure freedom is more likely. If you have underlying structural abnormality, tend to have more likely to have second or seizures. That's how we're differentiating. And that's also the same way with likely of pediatric patients are more likely to have less seizures and chance of having better outcomes. Now, this is the epilepsy definition of now we can talk about what is a seizure. This is not epilepsy. When you have more than one seizure, then you think about a patient is going to have an epilepsy condition and what are the consequences of epilepsy condition. So that's what here has been in this paper has been documented that you have to have predisposition. Predisposition means you have an abnormal EEG or a structural warning that shows you that the seizure is generated in the brain, and those are epileptic seizures. And then that has consequences associated cognition, psychology, feel, and the consequences is how your outcome will be, your performance will be. So you can have social disturbances, you don't get periods because you can have depression secondary to the epilepsy. So there are many consequences. So altogether is an epilepsy. So two seizures from brain cause you to give diagnosis of epilepsy, but there are other conditions which comes from seizure disorders. So practical clinical definition of epilepsy was proposed by International League of Society where they say if you have at least two unprovoked seizures, unprovoked is very important. That means you don't have any hypoglycemia or you did not have a head injury and that trigger or you didn't have a stroke because you can have immediate seizure after certain brain injury within the first 3 to 7 days. So that's why it's very important, unprovoked. So suddenly you were sleeping and start having a seizure, kind of a unprovoked seizure. And this happens if there are two seizure compounds 24 hours apart, then you got to diagnose it myself and epilepsy. You don't need to need EEG. Provided that there's a two unprovoked seizures, there's stereotypical the same symptoms happens all over. The second scenario is if you have one seizure and then we do an EEG and that shows that we have a propensity to have a seizure, then there is more likely that we will go to second seizure. In that case, you can be given benefit of not having second seizure and initiating the medicine. The reason behind that is, so for example, you're involved while you're walking and suddenly you fell down and you have a seizure. And your EEG is abnormal. But we don't provide you an anti-seizure medication for paralysis. Then there's a possible risk you're driving or crossing the street and you have a seizure. You can have an accident from that yourself. So this helps us in who we can withhold from starting medicine, who we can observe. Not necessarily every single patient. We need to start monitoring, and that's really helpful. So that's why we need to diagnose epilepsy syndrome. And that's what is different in pediatric epilepsy than adult. So, and we'll talk about some of these epilepsy syndromes which are common in pediatric age 2. So I think transpose both of them definition. So as I say, we can still move seizure 20 course apart, one core seizure, and then probably having 5 seizures in this. That means you have it from EEG or certain family history, which means us think that we're going to have second core seizures. And then this has to be within 10 years. That's very important that if you have 1 seizure, and then you have a seizure after 20 years, that may be not related to the same underlying predisposition as irreversible dementia. So this has to be within the 10 years. And the third one is diagnosing epilepsy syndrome. So in pediatric epilepsy syndrome, this is going to be divided based on age of the patient. So certain conditions, certain conditions of syndromic conditions are common in epilepsy. And those seizures resulting during the period may likely be just restricted in that period and not have or it happens during infancy and you won't see that happen again. So we will talk about certain syndromes. One of them in the infant epilepsy is infant spasm. So this is a epilepsy syndrome. Now we're not talking about what is the cause for this. We are talking about what seizure and what's associated with each finding and what are the specific laws we expect from this. Second is febrile seizures. And the third is the Dravet syndrome. It's a very long because of the shock that has been the first patient with a seizure part. So that was not seen. So infant spasm, it's a really infant spasm. State that they can have seizures, especially quality of life, especially a bit as well. The reason I'm saying this is very important is because and affect good health. So that's very important. I really making sure the patients do this better understanding. So all the mimickers of the treatment is about, especially the first 6 months, the babies are having other symptoms like cold. They usually do the same. So, or they can be started in circulating and being able to like the same movements, which is commonly seen and described either by clinicians or paramedical staff as maybe this is possible to see. This may be a common condition like COVID or sleep having big difficulties. So, but when an EEG is done, after we see this, right away we advise to get a diagnosis from like abnormal aortic EEG. So here you see, really nothing is so this follows normal spiky discharges we see common concerns, right? So just really high altitude. If you see this is really major medical activity, so this is typical EEG cause of lucidity. And this is normal to see at the initial onset, but usually once it starts with first procedures, we see that. And this is very important. We have to have a sleep record because you can see it when you can sleep in a way that are not being epileptic. So sometimes we can visit the definitely we need to sleep during this So these are the treatment people which has been still the same treatment for the last 30 years. There's no change. The first part is ACHs, SPHs, right? In other countries, Japan, services very quickly. US is standard. Nowadays, when most of the people they prescribe, they use over prednisone instead of basically there have been various studies documenting similar response. See the flux from parents. And here they're just blank stare and they're lost for the time being. If this seizure continues to last longer, then you have accidents that they may wet themselves, especially when they are in school, they are holding the urine and suddenly they have seizures when they lose their control. So this child was born normal, they have no antenatal problem, the development is fine, but they are struggling during school. And the family history shows that there is a history of abnormal seizures. So there may be other seizure type in the family, not necessarily just an absence epilepsy in the family. So this is very important as a family history to take. About 1 in 5 patients with acute absence seizures, they may have somebody else in the family having a history of convulsions or with the seizure type. They usually have a normal physical exam and clinical test. You can make the child to do hyperventilation, and that usually brings out the seizure easily in the office about 90% of patients, and that can give you a diagnosis. If you do an EEG, and here you can see those generalized spike and weird discharges which are rhythmic appearing, and then they last only 10 seconds, and as you hear, the child is hyperventilating at the 2 minutes mark, patient had about 12-second seizures, and then suddenly stops and returns back to self. So about 15% of the cases of childhood epilepsy, they have this childhood absence epilepsy, and usually they have onset within 2 to 10 years. So usually typical preschool or school children, early school children, they will be having those staring spells. Their development is otherwise fine, their neuropsychological state is otherwise okay. And periodical absence seizures usually last between 5 to 25 seconds, and then there is no post-ictal state, they are not confused. After that, they can continue doing that activity. And the PET shows, as I showed, a characteristic clear spiking wave. The prognosis is excellent because all these children, they likely to grow out between 10 and 12 years of age. Some do far later. There are only exceptions is male, especially younger than 4 years of age at the diagnosis. They are more likely to need more than one medicine to control the seizures, or they may be refractory more than 2 medicines to switch out in that case. Most of the time, the valproic acid or the suspension is the drug of choice, and 80% stop having seizures after starting the medication, but some are continue to have, and then memorization or other medications we will try in combination to help them. There are certain drugs which are contraindicated to gain this sort of sodium channel drugs which should be avoided. Now this is the Lennox-Gastaut syndrome. This is the bad epilepsy in childhood, and it is hard to control. About 3 to 10% of the children from childhood age, they usually have this. Either they evolve from infantile spasm into an Lennox-Gastaut syndrome, or they start as it itself de novo after 3 years of age, and boys are more affected than the girls. The long-term outcome, as I said, is poor. They are refractory to control. They usually have mental deterioration, completely they are delayed. And I'll just show one of the example of the seizure. This is a tonic seizure, which is a common seizure type in Lennox-Gastaut syndrome. So if you see, this looks similar to infantile spasm, but it is longer in duration, the stiffness, and then suddenly the patient stops, very relaxed, and after that has a clonic jerking. So this is a typical tonic or hypotonic syndrome. Now, we'll talk about anti-seizure medications. So these are the common epilepsy syndrome which you see in children of different age group. Coming now to different topic is anti-epileptic drugs which are commonly used in these patients. So we have old anti-epileptic drugs which are before the FDA started recommending trying in the clinical trials and documenting efficacy. These are the medications which are developed and used for treatment without any trials. Nowadays, these are the newer anti-epileptics which needs to be stringent criteria. They have to follow an FDA clearance before they can be used in people. The list has gone further.
effect of the first anti-seizure medication. So most likelihood, if I use a seizure medicine, my patient is going to show response and the seizure will control. So this is Pediatric and Martin Brody. These are the two excellent epileptologists in Glasgow, Scotland. They actually have a database where they have followed for more than now 35 years. So this was the first paper they published in 2021. They actually showed that time they only used 4 drugs, which are the carbamazepine, phenytoin, dilatin, valproic acid. And they actually showed that those patients who had idiopathic epilepsy, those did not have any MRI abnormality versus those who had abnormality in the MRI. They showed that if you use the first medication, the likelihood of response is less than 50%. And they documented that the most benefit we find is at low dose or moderate dose rather than the high dose. As we increase the dose, it's less likely of having benefit. So the moderate dose or the low dose would be better to have control with. The other thing is, as we increase the dose, most likely that we will have adverse effect increase as well. So here, the carbamazepine group, they had 88 patients had seizure freedom compared to sodium 0.58 and normoxin 48. So most important thing is when you try to use this medication, the percentage of the response is more with sodium valproate and normoxin compared to the carbamazepine medication, but it is not 100%. And they published a study recently in 2018, so this is a long, after 2 decades of the data, and they have launched a report which they actually showed that with more availability of anti-seizure medication, so now we have multiple medications available, not only those 4 medications which you used to use in the past, but there are many medicines we have available now. And still, the response rate is not high. So if you use seizure freedom after the first dose, it's 45%. And if you do 2 or more medications, still 2/3 of the patient only get control. So it's less than adequate. So any of this medication has been used, the percentage is less and less as we try more and more medications, but it's not reached 100%. So that's the reason 2/3 of the patient is going to continue to remain refractory to the anti-epileptic treatment. The CBD came into picture with Charlotte. Charlotte was a patient with the Tourette syndrome who was having 100 seizures per day, and they used the Charlotte web, the tincture, and they found that it is dramatic response from 100 seizures per day to few seizures per day, and a cognition improved. So this was the study done, which actually showed that they used cannabinoid oil, which is a purified form, and the placebo, and they showed patients based on seizure frequency from 12.4 seizures per month, and here in placebo 14.9 seizures per month. With the treatment period, the decrease in the seizure average from 12.4 to 5.9, and here is not significant difference. So they found that there's a significant difference of using CBD oil in the treatment. And overall, there is a response. There's no difference between the placebo group and the cannabinoid group, but there was a significant response they found in the patients with a seizure reduction. So this was the main important thing, that 25% to 50% they had a good response and reduction of seizures. There was only 4 patients in the study, they had seizure free, but they still continue to have seizures. So if you have seizures, when do we call a seizure an epilepsy to be refractory? So we'll talk about the definition of that, but before that, the cannabinoid oil has been used now for various conditions, like in Manus-Gastaut syndrome, there's in and the drop seizure, it has been found to be useful again in reducing the seizure frequency by 50%. The drop seizure, if you see here, the dose is 10 per kilo versus 20 per kilo, and is significantly reduced compared to the baseline. And the total seizure reduction has been decreased as well. While the non-drop seizures, there's a somewhat beneficial as well, but not with 20 as much as 10 milligram per kilogram. When do we call an epilepsy a drug-resistant epilepsy? That was a debate. So when do we start considering other alternative treatment for seizure for the epilepsy? So this was the definition proposed by ILA group, and they said that if we use two medicines in appropriate dosage and appropriate time, if they are well tolerated dose, then we can define that we have used two medication and the patient has still continued to have seizures. In that case, patient has been refractory for treatment. So most important thing is, as this medication used in adequate trial means it has been given adequate time period in an adequate dosage. And if there are two of this dosage, two of this medication have been used in good time period, then they are more likely to not respond to third or fourth medication, and we need to think about alternative treatment for epilepsy. So here, as I said, adequate trial. That means what was is the duration of the medication has been adequate. So whether patient is having 3 to 4 seizures a month, and if we try for 6 months and continue 3 to 4 seizures, then it's called less likely that this is going to be beneficial. Similarly, if the dosage has been used appropriately, so the drug is appropriate for that condition. So sodium valproic acid is used for generalized convulsions for absence seizures, but if ethosuximide is only used for absence seizures, so if we use ethosuximide for generalized convulsions, then we cannot say it is an adequate or appropriate treatment. So we need to make sure that we are using appropriate medicine for that condition. And that's what the appropriateness for the seizure diagnosis we use it. So this is why we should consider inappropriate for focal seizure or for convulsions. Now, proposed criteria for referral. So once we have diagnosed a patient with refractory epilepsy, when one should be referring to a specialized center for further evaluation, because now we don't want patients to continue to have seizures. As seizure continues, patients more likely to become refractory and have stronger seizures. So there have been centers who has been developed specifically to address this, and the reason because we need, and this is different in pediatric group compared to adult, because pediatric brain is a developing brain, so we want to make sure that epilepsy is different, as we've seen infantile spasm does not occur in adult. So we need to have a center which is specialized in pediatric to take care of epilepsy patients with complex conditions. Their development is going to arrest if we continue to have epilepsy, so that's why we need to make sure that we have developmental assessments and assessment available for this patient as well. So that's why you need a specialized center to refer them. And there's a plasticity, so the brain is continuing to change over the time, so that's a unique setting in pediatric compared to adult. So we need to make sure that we have a specific center to take care of all this developmental and psychosocial aspect. So what are the evaluations we do for patients who have refractory epilepsy in epilepsy center with specialized abilities? So one is the EEG. EEG is a basic test we do to diagnose any patients with epilepsy, to diagnose what kind of syndrome has it and what type of epilepsy patient has it. Now, usually we do surface electrode replacement, so that's called EEG. And if we do longer time to capture patients' seizure, that's with a video. This is a gold standard to document patients' epilepsy syndrome. This is what is done in a specialist center, not available Once we diagnose patient as a surgical candidate, then we offer an invasive electrode after other evaluations to help us define the patient's epilepsy zone. Structure imaging, this is what we need, specific MRI studies, which are part of the high definition MRI. This is not available at every centers, and this is required in order to define the patient's abnormality. And this is usually done after the first 2 years of life because the validation is an issue in the first 2 years in the child development. So this is the reason we recommend doing MRI brain after second year of life. And sometimes we need a serial scan, so first scan is not available. I mean, it's not showing an abnormality. This means the patient does not have it, but once we evolve, then we may see some abnormality over the time because of the validation issue. The other test which we do with the MRI is a functional testing and a SPECT scan and FDG PET scan. The neuropsychological data we want pre and post surgical. This is because the child's brain is a developing brain, and we want to make sure the area which is functioning for learning and is there a dysfunction in that area because of the epilepsy. That's why we need a pre-surgical evaluation. And if we do a surgery, what is the impact on the patient's development of the brain function? That's why we need post-surgical assessment. In the pediatric age group, there is no psychiatric conditions which has been an exclusion criteria for patient referring to epilepsy surgery. So the structural imaging, which is important, why it has to be done in a specialist center. Here it shows that when we use a higher magnetic field, so in previously 10 years before we used to have 1.5 strand magnet, now we have 3 strand magnet, so 3 Tesla magnets, so that means it actually helps in differentiating the signal to noise ratio so we can see better images. And here, this was the study which was showing that what's the rationale of doing a 3D MRI with a high resolution scan. So if here there was 101 patients who had normal 1.5 strand MRI, and after they've gone through a 3D MRI, that means the strength of the magnet is double, there is a more likelihood of having patient find abnormality on the MRI. And when we do high resolution scan, what is a high resolution scan? It means thin slices of the brain scan, then we are more likely to see abnormalities. So of those 101 with a 3D scan regular, we had found 57 patients, but of those 44 patients who did not find when they did a high definition scan, then they had more 29 patients having found a focal cortical dysplasia. So I think that's very important that this is the 1.5D MRI, this is the 3D MRI, and this is a 3D resolution scan. So that helps us define an abnormality. Now the functional scan is a SPECT scan. A SPECT scan is a glucose scan which we do one with the seizure and second without the seizure. And this is difference between the seizure and without seizure scan that is help us identify the area of abnormality which is picking up the glucose, and that can be the area of interest for seizure onset zone. So in this study, they actually show that this is an abnormal area we can see. Now, is it the area abnormal looking is enough, or we need to find a functional area as well adjacent to that which can help us decide whether we should be doing surgery. So, and this is the area of abnormality they have defined on the scan. This is the scan, which is the SPECT scan, where you can see the glucose uptake is close to the area, but not exactly at the place. When they reimpose the SPECT scan image over the MRI, this is the structural region, this is the SPECT scan, and this is the part of the SPECT scan close to that overlapping structure. When they removed that part of the area, then they were able to get a seizure freedom on this patient. So that's really important that the structural abnormality, along with the functional abnormality, correlated very well, and the resection of that area helped in controlling this. Similarly, the PET scan. PET scan is a different functional test. In this case, we give, while the patient is not having any seizure, we give a glucose dye, which is a radioactive substance, and the patient is rested in the PET scanner for 20 minutes, during which the scanner, the glucose radioactive substance which takes out the radiation has been picked up by the machine, and that actually forms an image. So in this case, there were MRI images were 158, which showed normal MRI. And when they had taken the PET scan and then looked back at those 158 patients with normal MRI, they were found 72 patients having abnormality in the PET scan. When they looked back at the MRI, they found abnormality in the MRI. So that is the way it is useful for patients with normal MRI to find a lesion, which may be ability to identify this, whether this is epileptic zone. So this is an example of the FDG PET scan, where you can see these are the temporal lobes on the side. You can clearly see the red is where the pressure has been uptake, and the green is where there is no uptake. This is a poor zone, and this was more abnormal for this. When the MRI was looked back, it was found to have an abnormality, and this was the site of the patient's seizure focus. Similarly, MAXscan has been used, which is a magnetic scanner, and that has been used for defining abnormality in the intellectual abnormality deeper into the brain structure. So we do cognitive testing, which is neuropsychological testing, to help define patients' strengths and weaknesses. And usually we try to see memory, attention, motor and sensory functions, as well as language. And one of the reason of doing the language assessment is dominance of the hemisphere, which side of the brain is more likely to perform the functions, and that's what we do a lot of tests, where we give an hemobarbital dye through a angiography to the brain to make one part of the brain to fall asleep and then decide the patient's function. So there is a test of battery test of the battery of the object being shown to the patient while the patient is given one part of the brain being asleep. And then we see whether the patient is able to remember. So that's what is a lot of tests to help us decide whether that area is doing function in memory or not. These are the other surgical procedures which we do. Once we decide if the surgery is feasible, then we can do invasive EEG. We can do electrocardiography by putting the electrodes on the surface, or we can use a clean electrode like this to put a depth. And this is the surface reads what we see on plain X-ray. These are the depth electrode which you use and can be put into the brain. So this is the stereo technique device that what we use to implant this electrodes inside the brain to monitor. And there are pros and cons of which one is better than the other. The most important thing is that the electrode is less invasive compared to this circular electrode, but these are more better because there is a area of the brain which is uncovered in a continuous manner we can assess compared to this which are not congruent to one another, and that is the reason we probably better circular for certain reasons, but these are less invasive and less complications, so this is more important. So there are various types of surgery, but this is out of scope for this talk, which is the pediatric epilepsy. But just to show that we can do part of the brain, which is temporal lobe, we can do dissections to help control the seizure. If there is found to be an area of interest. We can do palliative surgeries like hemispherectomy, sort of separating one part of the brain from the other, which is called as hemispherectomy, and this is especially done in one part of the brain either having stroke, in utero, or having development of brain abnormality, or in the last muscles encephalitis because of the inflammation of the brain on one side, which can cause the patients to have continuous seizures. The other surgery is dissecting surgery, as I showed you, for lobectomy or hemispherectomy. And the corpusculostomy is a behavioral surgery where we do dissect the two sets, we disconnect the two sets of the brain by the connecting corpusculosum, and that is usually done for 800 drop seizures in Lennox-Gastaut syndrome. This is just for palliative. Sometimes it has been done in generalized convulsive seizure as well. So the efficacy is 90% reduction in patients who have drop seizures, so that's been found to be very helpful compared to other modalities of the treatment when they are not responding to the treatment with the medication. So this is actually the part of the corpusculosum, and this is the completely anterior part of the corpusculosum being removed, and this is the complete removal of the anterior corpusculosum. It has been found that compared to the anterior third, if you remove entire the corpusculosum, then it's more likely to benefit in the seizure reduction. Neurostimulation has been used on devices to use to actually reduce the seizure frequency, seizure burden, and this is not for cure, but it is for control of the epilepsy. Mind note that this all have the lifespan of the battery, and also battery is lifespan is over, then we need to replace that. So that's very important that we need to keep replacing the battery. But this is a good device, and it works in about 2/3 of the patients in reduction of the seizure, and rather than less than 10% of the patients can be seizure free as well. So this is a vagal stimulator, which is outside the brain, but it's connected to the vagal nerve, and that can help in reducing the seizure frequency. So this is the device which is called neurophase responsive stimulation, and this is within the brain in the area which is we can't remove, but the patient has a seizure, and then we can control that. That's called as a responsive neurostimulation. And now the latest is we can actually stimulate the deep brain structures, and that is called as the deep brain stimulator therapy in controlling the seizure as well. And this is usually done in the thalamus, but usually done in bilateral both sides. There are pros and cons, but it has been found that it can reduce the seizures and various types of seizures, not just partial, but can be used for the generalized seizure as well. There are differences, but the most important thing is cost effectiveness of pediatric epilepsy surgery. This is a debate because surgery is not a cheap option, but what is the likelihood of surgery doing better? So there has been studies done that show that if you continue to have a refractory epilepsy over the time, the anti-seizure medication costs, recurrent ER visits, and prolonged dependence, stability, that is more likely to cause expense to be higher than the surgical cost. Also, the lifestyle will be really improved with the surgical treatment option, especially if the seizure is fully controlled or markedly reduced. And this has been the data that shown that is really effective with the surgical group. There is more likely to have a lifestyle improvement. And the cost-wise, also this has been shown that net benefit is about $3,000 more. So this is really helpful. If we reduce the seizure percent by 1% of the seizure reduction, this is the cost we can benefit. So it is very important. There are data from the social studies that have been done, patients who have had seizures for a long time period, and they have shown that patients who have had seizures for 5 years, and then once they got epilepsy surgery done, the seizure life totally changed for the patient, for the family, and this has been really benefit for to consider, especially in cases where we can make them seizure free without having any deficits, unlimited deficits. SUDEP is another common thing which is not discussed, but this is the first time we should be discussing it. I mean, families that if the patient is convulsant, more likely to have a risk for sudden and unexpected death in epilepsy. And there have been studies done which has been now showing that there are predisposition genetic profile which can make you more likely to have a SUDAC compared to others. And with the patients who have convulsive seizures who are not controlled, then they are likely to continue to have more risk for having SUDAC, especially if they happen unobserved in generalized tonic-clonic seizures, likely to be more associated. And both adults as well as pediatric population, they are at risk, and it's more likely to have 1.3 per thousand in 100,000 years versus you likely to have an incidence of seizures, and continues to evolve. And finding out the patient's population or more risk and how can we prevent that. So the most important thing is to stop epilepsy, stop the seizure. That should be our goal, and try to help the children and the adults safe. Any questions? Any questions in the audience?
Thank you so much for being here today.